So next I invite Dr. Thomas Arun Vargese to speak on optic neuritis, mimickers and masqueraders.
Good afternoon. At the outset, I'd like to thank KSOS and Dr. Nina for this opportunity. So, many cases we think, especially young female, we think it's optic neuritis. But sometimes a detailed examination will tell you that the cause is something quite different. I acknowledge my mentor in neuroophthalmology, Mr. Barr, and every case looked upon like a case of Sherlock Holmes. So these are different cases of optic disc edema, and only the one on the left, middle left, is optic neuritis. All the others were very different etiologies. And we'll go through these one by one. So history, examination, investigations are very useful. History, you use your ears. Examination, you use your eyes. And then you use what is between your ears to come to the diagnosis. Approach to disc edema, you can use, these are your tools. And as I said, additional symptoms, I'll give you a big clue. Differentiate true versus pseudo disc edema, unilateral versus bilateral. As you know, in optic neuritis, usually it's a unilateral presentation. So mainly cases of unilateral disc edema would become in your differentials. Don't forget blood pressure, general examination. I'm feeling the temporal artery here, any fullness of temporal fossa, and additional features. So true versus pseudo disc edema, that's the first thing you need to differentiate. So the two most useful C's, the color, cup, contour, circulation, and complete retina. The cup, as you know, in true edema, it goes late, while it lost early. It is absent very often in pseudo disc edema. And circulation, the C's. The blood vessels are usually very clearly seen in pseudo disc edema. And as I said, typically optic neuritis, you're thinking of unilateral causes like posterior scleritis, uveitis, AION, neuroretinitis, and compressive lesions. And very unusually, bilateral cause, those causes which present usually bilaterally may start in one eye and then in the other eye. So I am a clinical person. I mainly look at additional features in the examination. For example, a pale optic disc indicates an AION, and additional features like a macular fan indicates a neuroretinitis. If there's associated choroiditis, you're thinking TB. If there's associated proptosis, it can be very mild. You're thinking an orbital mass. Extreme severe pain generally indicates an posterior scleritis, and I'll show you examples of these. So this is a lady I saw when working in the UK, 3 weeks, blurring of vision left eye. You can see the disc edema, and she also had the fullness of the temporal fossa, and that indicated a bony lesion, and that was very beautifully seen on the CT scan, which showed a fibrous dysplasia. So as general survey of the patient will give you important clues as to the possible cause. Again, 35-year-old who presents with blurring in the right eye, but you see the other features. You see the extensive cotton wool spots. That indicates a systemic cause, and it's actually due to hypertension. This is a very interesting patient, typical optic neuritis age group, 29-year-old with disc edema, and you can see she had a doubtful choroidal elevation infranasally. So I evaluated for tuberculosis, MAN2, and when she came back with the MAN2, she had developed a new lesion, which you can see here supratemporally, and there's a subretinal abscess. So that indicated possible tuberculosis, and we started ATT, and she had a very good outcome with the ATT. So although the typical optic neuritis age group, it was a very good decision not to whack her on IV methylprednisolone for 3 days. So uveitis, the important clue was the anterior vitreous cells and the small choroidal elevation. Again, a 40-year-old presented with blurring in the right eye. You can see the disc edema and some pallor, but you examine the other eye, it's almost like a chronic papilledema, almost like you have the typical champagne cork appearance. So this was actually an AION in a papilledema. So when in a chronic papilledema, they develop a compartment syndrome leading to AION and sudden worsening of vision, which can simulate an optic neuritis. A 65-year-old who presented with blurring in the left eye. Again, you can see this disc edema in the left eye, but the other eye examination showed pallor. So you had pallor optic atrophy on one side and disc edema on the other side. And this is a case of Foster-Kennedy syndrome. So even though the present symptoms is in the left eye, very important, always examine the opposite eye, which gives you important clues. Very interesting patient here, 39-year-old, presented with severe headache and pain and photophobia. Actually, I was not even able to examine the fundus at the first visit because of the marked photophobia. Gave topical steroids for a few days, came back in 3 days. I was just about able to examine the fundus and take this photograph, which showed a disc edema in the right eye. And her pain was sort of out of proportion to the congestion. So I was suspecting a posterior scleritis, which it turned out to be with the B scan, but the story did not end there. We gave obviously high-dose systemic steroids, and she responded. So disc edema with severe pain, you're thinking posterior scleritis. But the story, as I said, did not end there. She came in 2019 with some complaint in the left eye, and you can see an exudative retinal detachment. Again, we gave her systemic steroids, and that settled down. And at that point, examination of the right eye showed a sunset fundus. So this was actually a VKH presenting with posterior scleritis, but presenting first as a disc edema. And 4 years down the line, we got the diagnosis of VKH. And again, the exudative retinal detachment settled very well with systemic steroids. A 16-year-old 11th standard student presented with some pain, blurring, and she had features of panuveitis, anterior and posterior inflammation, and bilateral disc edema. So you're thinking sarcoidosis, TB, toxoplasmosis. ACE was very high, and she was started on systemic steroids, responded initially. She even developed a facial palsy. She phoned me one day and said, "My face looks a bit funny," and sent me this photograph. So she had developed a facial palsy. Again, we increased the systemic steroids. She even developed new vessels on the disc. We did a PRP, and finally, she is doing very well. So started off with the disc edema, but additional features. So always the additional clinical features gives you important clues. The uveitis features, suspected sarcoidosis and TB, and gave a good result. Last patient here, 31-year-old. He had a present with some blurring. He's a professional driver. And actually, he actually didn't think anything wrong with his eyes. He got married during the COVID time, and his brother-in-law, who was watching the wedding online, said, "Your eyes look a bit funny. You better go and see an eye specialist." And he came. You can see there was disc edema on the right side and a mild proptosis. And so disc edema plus proptosis indicates an orbital lesion, and he had a cavernous hemangioma. And Dr. Marian operated him, and you can see he's done very well. So take-home message: detailed history, focused examination, differentiate true versus pseudo, unilateral versus bilateral, look for additional features. There will be some additional features which will help you differentiate from a typical optic neuritis. Systemic examination, blood pressure, don't forget, and investigations, blood and imaging where necessary, will give you the diagnosis. Thank you.
Thank you, Dr. Thomas Arun. Dr. Thomas Arun Vargese is a very senior consultant working in Cochin at many hospitals with special interest in neuro-ophthalmology and glaucoma.